Hello, and thank you for joining us today at the South Carolina Office of Rural Health as we discuss the Critical Access Hospital designation. My name is Emma Jackson, and I will be taking you through today's webinar. Here's a quick agenda of everything that we will cover today. I will dive more deeply into today's objectives, but I just want to list everything that we are going to discuss, and I briefly want to introduce myself. Again, my name is Emma Jackson, and I am the graduate assistant here at the South Carolina Office of Rural Health, and I work with the Health System Innovation team. You may be more familiar with our director, Sarah Craig, and our program manager, Britton Herbert, and the work that they do to facilitate supporting small rural hospitals here across South Carolina. By the end of today's webinar, I hope you have a better understanding not just of the Critical Access Hospital designation, but really how it fits into our programs and initiatives here at SCORE, as well as the specific eligibility and requirements outlined under this designation type, as well as what the application process and technical assistance process looks like through our office and through other rural health stakeholders. Finally, we'll end by looking at some possible opportunities for conversion through this model here in South Carolina. But with that being said, I really want to draw attention to the work that we do here at the South Carolina Office of Rural Health. In speaking to our mission to close the gap in health status between rural and urban communities, the Critical Access Hospital works to facilitate this work with small rural hospitals. And chiefly, we're going to focus on two main rural hospital programs that our Health System Innovation team works with: the Medicare Rural Hospital Flexibility Program, or FLEX, that allows us to engage critical access hospitals here in South Carolina, but also the Small Hospital Improvement Program that allows us to engage small rural hospitals with less than 50 beds that have been deemed eligible in our state. With that being said, this is just the work that we're going to be focusing more on the work that our Health System Innovation team does. But for a more comprehensive look at all of the programs and initiatives here at SCORE, I do want to point towards our annual impact document from 2022 and point reference to that, and that is now available through our website and is a great resource for you to check out. But first, in focusing on Flex, I really want to highlight the 5 main objectives of this program so that you have a better understanding of how we are able to engage cause here in South Carolina through our office. For starters, through this program, we're able to initiate operational, financial, and quality improvement initiatives, all with the hope that small rural hospitals can adopt best practices within their system, all with the underlying goal of closing the gap that exists between rural and urban communities. That is the core goal of our office here at SCORE. In addition to those two domains, we also want to work to facilitate population health improvement through the FLEX program so that hospitals are able to better address the health outcomes of the populations that they serve. Finally, with those domains in mind, we're also able to engage emergency medical services and support the vital services that bring out health into the communities and that facilitate transfer to their local hospitals for care. Finally, and perhaps most relevant to today's topic, through the FLEX program, our office is able to initiate innovative model development so that we can provide health system innovation that works to support all 5 of the domains that we have discussed. And really, one of the ways that works is through the Critical Access Hospital model. Now, before we go into the specific changes that have occurred through the Critical Access Hospital model within the last year, I do want to discuss how this model functions to really underscore the role that it plays within the rural healthcare landscape here in our state. With that being said, the Critical Access Hospital designation really works to preserve the financial viability of small rural hospitals that act as cornerstones for providing health services to the areas they serve. Through this model created by CMS, hospitals are able to receive a few key benefits. These benefits include cost-based reimbursement, technical assistance resources provided through the FLEX program, and also more flexibility as a facility through their services and staffing. In addition to these benefits, it's also important to discuss major changes that occur within participating hospitals as far as compliance, and that costs do have a 25-bed limit and an annual length of stay of less than 96 hours. So these are just a few hallmarks of this model to consider. They may be a review to many of you, but they are important to discuss as we now go through of some of the factors that precipitated the creation of this model and why there's still a need for this model in rural healthcare today. In looking at the current state of rural hospital closures here in South Carolina and across the United States as a whole, really one can begin to see why rural hospital models serve an important role in providing alternatives to complete closures. Within the United States, 190 hospital closings have occurred since 2005. With regard to South Carolina, I really want to point to this map here on the right, which illustrates the number of closures that have occurred in our state since that time. With 4 hospital closures occurring in our state, it really facilitates the discussion on what rural hospital challenges exist that are causing these closures. In references to challenges, I do also want to point out that a few have been identified through current literature in our state's healthcare landscape, while also noting this is not an exhaustive list of all the issues that rural hospitals are facing in our state. With that being said, since before the creation of the critical access hospital model to today's time, rural hospitals have and continue to experience issues related to regulatory challenges, declining reimbursement, low patient volume, access to care, and workforce shortages. Many of these issues have since been exacerbated by the pandemic and will continue to be challenges after the public health emergency ends here within the next couple of months. In drawing attention to those challenges and rural hospital closures, I hope to highlight some of the underlying reasons that the critical access hospital model was created and why it still serves an important role to this day. In addition to those 190 closings that we discussed that have occurred since 2005 across the United States, over 400 rural hospital closures occurred before this time in the 1980s and 1990s. At that time, key stakeholders in rural health began to call for legislation to address this issue that was causing financial vulnerability for rural hospitals. It was this discussion that led to the ratification of the Critical Access Hospital designation type in the Balanced Budget Act of 1997, so that it could serve in the role that it does today in seeking to provide rural hospitals more stability on a financial front. The Critical Access Hospital model achieves this goal through a set of eligibility and conditions of participation requirements, those of which we're just going to discuss now in more detail. Now, the Critical Access Hospital model was created through the BVA with 3 main stakeholders in mind. These are outlined as rural hospitals that are certified Medicare participants and that are licensed to provide acute care, hospitals that served as licensed rural hospitals but had since downsized to rural health care clinics or federally qualified health centers, and finally, rural hospitals that had closed after November of 1989 but that had met COG conditions of participation upon closing. With these 3 facility types in mind, the critical access model really allows for rural hospital models to operate under this designation through a specific set of requirements that we're. Now, in going through each of these requirements, I'm going to highlight changes to specific criteria that have had changes in the last several months and that have possibly created new opportunities for hospitals here in South Carolina to convert to this designation. But I first want to draw a point that to operate as a critical access hospital, a hospital must be located in a county that is recognized as rural. They have to be located in a state with a Medicare Rural Flexibility Program, or such as South Carolina, and they have to be a certified Medicare participant. Now, recent changes have occurred with regard to the distance requirement, and now that hospitals have to be located more than a 35 miles from other hospitals or CAUs with a 15-mile exemption specifically regarding mountainous terrain and secondary roads. Now that new changes have really occurred with regard to adding language regarding secondary roads, which again we'll discuss in more detail. Or the hospital has to be designated as a necessary provider. In addition, hospitals have to have 24-hour emergency services available. They can have no more than 15 acute care beds with up to 25 beds for swing bed facilities. Hospitals have to have an average length of stay per patient less than 96 hours, and they have to meet conditions of participation outlined in the Code of Federal Register. Again, we will discuss those specific conditions of participation in more detail. Now, with regard to the distance requirement, I do want to highlight a few key changes that were recently made by CMS to the language in the distance requirement regarding secondary roads. Now, originally, a hospital had to meet either the 35-mile distance requirement from other hospitals or CAUs, or they were able to be deemed as a necessary provider by SCORE, which superseded the distance requirement. However, that authorization expired by CMS in 2006, and since that time, we have not had any additional hospitals convert, as all of our CAUs, as they exist now, were deemed as necessary providers upon creation. With that being said, recent changes have now specified that hospitals can qualify for the 15-mile requirement if there is, again, evidence of mountainous terrain or if there are 15 miles or more present of secondary roads. Now, you may have the question, what qualifies as a secondary road? And looking at this illustration here on the right, you can see that a secondary road is defined, or what we would more commonly refer to as a 2-lane road with 1 lane going in each direction. In contrast to that definition, a primary highway is typically a numbered highway that has 2 or more lanes, as shown in this depiction, or more commonly known as a 4-lane or multi-lane road. It's important to note this change because it highlights that there is potential for additional hospitals to convert under these new requirements, and we will discuss some of those opportunities towards the end of this webinar. But first, I want to draw attention back to the CAU model specifics and discussing the payment system of this designation type. Now, in looking at the specifications with regard to inpatient and outpatient services, hospitals will be reimbursed at 101% of reasonable costs. In addition to any swing bed services they might be rendered are going to be given under this additional cost-based reimbursement. With regard to inpatient rehabilitation services or psychiatric services, those specific services are going to be rendered under the prospective payment system rates for those specific types. Finally, with telehealth services, any services rendered under this category are going to be given with regard to 80% of the physician fee schedule as outlined by CMS. But overall, this payment system really seeks to aid hospitals that may be financially vulnerable, but it is important for hospitals who are considering conversion to analyze how these changes would impact their payment methodology, as well as how the conditions of participation outlined would affect their hospital and whether or not converting to a CAH would be feasible for them. Now, in discussing the conditions of participation, I do want to highlight a few hallmarks of this model. Hospitals that are looking to convert to CAH status have to have an agreement with a hospital or a qualifying entity for credentialing and quality insurance. In plainest terms, they have to participate in a rural health network in their state and demonstrate that they can do so. Second, there are personnel requirements for each appropriate staff member and how they should render care under their license. Additionally, CAHs have to meet certifications, both given by CMS and at the state level, as far as designation and certification. And then, with regard to emergency preparedness, hospitals have to develop and maintain a program for emergency preparedness for their specific hospital. Additionally, with regard to those conditions of participation, hospitals have to have a facility-wide program in place that's going to demonstrate that they are doing surveillance, control, and prevention of infections within their facility, and they have to demonstrate optimal utilization of antibiotics through an existing stewardship program. Second, hospitals have to have an effective quality assurance program and arrangement with a qualifying facility that is really going to work to evaluate the quality of treatments and diagnoses that are being rendered within their rural hospital. Finally, the last condition of participation I will make note of is that a CAH has to have existing discharge planning process in place that's going to emphasize patient goals and it's going to correspond with their treatment preferences. Again, this is not an exhaustive list of the conditions of participation that can be found under the Code of Federal Register, but it is important for hospitals to keep these in mind in considering whether or not this designation type is for them. Now, in speaking to specific quality measurement reporting requirements, there is an existing program in place for this called the Medicare Beneficiary Quality Improvement Project, or more commonly known as MBQIP. Now, through MBQIP, any flex participants in our state, are required to participate, and through this program, they have to report on at least one core measure within each of the 4 domains in each quarter that they operate as a CAH. Now, the 4 domains under MBQIP have measures with regard to outpatient care transitions, patient safety, and inpatient services, as well as patient engagement. So hospitals need to consider whether or not they would be able to comply with these reporting to these measures before they convert to CAH status. Now, for hospitals considering converting to the critical access hospital model, there is a designated process in place for the application through our office. And this process is really broken down in its final form to the process mapped as outlined here. Now, through this process, hospitals do have to submit a letter of intent to our office saying that they would like to convert to this designation type, at which time a financial assessment and an application process in combination will be conducted and will be received by that hospital, so that can be reviewed by our office and sent to CMS. At that time, CMS is going to authorize a survey through the state survey agency, which for our state would be SCDHEC. And simultaneously, as this process is occurring and a survey is being conducted through those agencies and we're working with additional stakeholders, the 855A form that is part of the application package is going to be sent to the Medicare Administrative Contractor to approve a change in designation. And at that time, all of these stakeholders will work together to conduct a final application review by the CMS regional office and state agencies, at which time they're going to come to a conclusion that is going to notify this hospital of their approval or denial in applying to the COD designation. Now, throughout this process, SCORE is able to facilitate technical assistance through three main different areas. And these areas really start by identifying interested hospitals for the COD designation, by providing COD education and training, such as through webinars like the one provided today. And finally, we're able to facilitate the COD application process through that designation kind of map that we just outlined. But overall, we do serve as the state agency for applying for the COD designation. With this technical assistance and recent changes to the distance requirement in mind, our office does want to highlight a few opportunities that may exist for hospitals to convert to the COD designation. Now, currently, there are 3 CODs here in South Carolina, which are illustrated in green here on the right on this map. However, now that the distance requirement has changed with updated language on the secondary roads requirement, our office has really seeked to highlight any additional opportunities that exist in our state, and those are highlighted through the for hospitals that are shown here in orange that are prospectively eligible now based on that requirement alone. Now, it is important for these hospitals that we've prospectively identified to consider if they meet the current COD conditions of participation outlined throughout this presentation, while also mentioning that our office is available to support any hospitals that are seriously considering conversion. But overall, we hope that now that we have reached the end of today's presentation, that you can see that the opportunities are present for hospitals in our state to convert to this model, whether that be now or in the distant future, and that our office really serves as a hub for these resources to learn more about the critical access hospital model. With that being said, I do want to end today's webinar by thanking you for joining us here at SCORE to learn more about this important model, and I will leave my contact information here should you have any questions and want to contact our office. But again, thank you so much for tuning in today and learning more about the critical access hospital model.